Hi, everyone. My name is Alice Tseng. I'm a pharmacist at Toronto General Hospital and Associate Professor at the Faculty of Pharmacy, University of Toronto. I'm also part of the CHAP Executive. And today I'm excited to start us off on a three-part HIV 101 series on antiretroviral drug-drug interactions. My goal is by the end of this three-part session, people will be able to describe the key mechanisms which are behind clinically relevant drug-drug interactions with modern antiretrovirals, be able to identify high-risk antiretroviral and co-medication combinations, and be able to apply a practical, structured framework to assess, prevent, and manage drug-drug interactions using reliable drug interaction resources. Or in other words, as I sometimes like to think of it, coming into the Zen of drug interaction management. Before getting started, I would like to acknowledge that at the University of Health Network, we're situated on the traditional territories of the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we're extremely grateful and privileged to have the opportunity to work, live, and learn on this territory. These are my disclosures. I want to acknowledge that the content of these presentations are entirely my own, with no input from any third-party company. So let's get started. Part one today, what we'll cover are some of the main basics in terms of terminology and mechanisms of drug-drug interactions. We'll discuss some of the main considerations of DDI risks with older versus more modern therapies. And we'll focus on inhibition interactions with a discussion about some similarities and differences between PK boosters. To get us started, let's go over a few common acronyms that you'll come across in this area. First is DDI, which stands for drug-drug interaction. People who are familiar with older therapies might also recognize that this used to be a common acronym for the older drug didanosine, but that is not what we're talking about in this context anymore. PK stands for pharmacokinetics. PK interaction occurs when there's a change in the amount of drug in the body due to interference with drug absorption, distribution, metabolism, or elimination. PD stands for pharmacodynamics. PD interaction occurs when there's a change in the effect of a drug. This change can be additive, synergistic, or antagonistic. For instance, if we take the example of tenofovir disoproxil fumarate and cisplatin, both are associated with nephrotoxicity, and you can increase the risk of side effects by giving them together. An older example of an antagonistic interaction is the combination of zidovudine and stavudine, as these are both thymidine analogs and will compete for the same active site, so they're really acting against each other. Boosters or PK enhancers are drugs which interfere with the breakdown of another drug and allow the boosted agent to remain in the body for a longer period of time at a higher concentration. Ritonavir and cobicistat are considered boosters and are not counted as active HIV drugs within a regimen. Now, pharmacokinetics is sometimes referred to as a drug's journey throughout the body, and you might see the acronym ADME, which refers to the following steps of this journey. Absorption refers to how the drug gets into the body, and it's the movement of the drug from the site of administration to the bloodstream. Distribution refers to where the drug goes. A drug will move from the absorption site to the plasma as well as tissues such as brain, fat, and muscle. The graph on the left shows a typical concentration time curve after a drug is administered. The goal is to have drug concentrations within the therapeutic window, as shown by the pink arrow, so that it is effective without causing toxicity. Metabolism refers to how a drug is broken down, and elimination refers to how the drug leaves the body. There are two important systems involved in drug metabolism, and these include drug metabolizing enzymes and transporters. The cytochrome P450 system is a superfamily of microsomal enzymes primarily located in the liver and small bowel, which chemically oxidize or reduce drugs in endogenous substances. CYP3A4 is the most common enzyme involved in the metabolism of pharmacologic agents. UDP glucuronyl transferases, or abbreviated as UGT enzymes, are involved in glucuronidation of compounds in order to make them more hydrophilic or water-soluble, and thus easier to eliminate in the urine or bile. A common UGT enzyme relevant for drug-drug interactions, particularly with antiretrovirals, is UGT1A1. Drug transporters in the small intestine, liver, and kidney mediate cellular uptake and efflux of xenobiotics. Transporters involved in clinically significant DDIs include P-glycoprotein, or PGP, breast cancer reducing protein, or BCRP, and organic anion transporting polypeptides, or OATPs. Now, bonus question. What does CYP450 actually stand for? Well, this term is derived from initial beliefs that these enzymes are thought to be similar to mitochondrial cytochromes. They are red in color, so P for pigment, and they maximally absorb light at 450 nanometers wavelength under certain conditions. And so if you look at the abbreviation CYP3A4, what it's telling you is CYP is the superfamily, 3 refers to the family, A is the subfamily, and 4 is the isoenzyme. So in other words, this tells you its place in the family tree. Some additional terms that are commonly used when we talk about drug interactions include substrate, or sometimes referred to as the victim drug. And this refers to an agent which is metabolized through the CYP450 enzymes and or taken up by transporters. Inhibitors or inducers are sometimes called perpetrators. These agents affect the rate of drug clearance of the substrate drug and can lead to increases or decreases in drug concentrations. This is an example of the different CYP450 enzymes that are commonly encountered, with some examples of substrates, inhibitors, and inducers. So you can see quite a number of different drugs and pathways. Now, it's important to remember that when we think of drug interactions, it's not just an interaction between a drug and another drug. Drug interactions can also occur between drugs and food, drugs and supplements, or even medical conditions, which can impact how your body processes drugs or combinations of drugs. And these outcomes can include decreased concentrations, so therefore decreased activity, or increased concentrations, which is sometimes good if it can make a drug more effective, or not desirable if there's a risk of increased toxicity. Another point to keep in mind is that interactions are not just a one-way street. So it's not just one drug affecting the other. Often there can be a two-way interaction, or as we know, people are, very rarely just on 2 drugs by themselves. There can be, if you have a lot of different combinations in the mix, you can get certainly more complicated interplays between all the different medications somebody's taking. Now, when considering the drug interaction potential of a particular agent, there are a couple things that I always like to think about or ask myself. One, can it be a victim? So is drug absorption affected by anything? And how is it metabolized or cleared? And then 2, can it act as a perpetrator? So does this agent inhibit or induce enzymes or transporters? So using this framework and looking at antiretrovirals, what we see is that protease inhibitors are generally considered very high-risk agents, very strong perpetrators of interactions because they're very potent inhibitors. And in RTIs, the older ones are moderate inducers. And then as you go further down, the newer agents and reverse transcriptase inhibitors, there's even less likelihood of drug interaction potential in terms of being perpetrators. Now, that being said, almost all of these classes are also at risk of being victims of drug interactions. I think a relevant question that people have is, since these newer antiretrovirals tend to be safer, are drug interactions even important with current day treatments? Or, in other words, do I need to start looking for a job? Why are we here? Well, what's been shown is that despite a shift to primarily use of second-generation integrases, which do tend to be very neutral in terms of causing drug-drug interactions, in fact, the prevalence of clinically relevant drug-drug interactions has remained stable. If you look at this figure on the right, it represents results of a systematic review of studies which reported the prevalence of clinically significant drug-drug interactions from 2006 to 2018. And over this period of time, the prevalence of amber and of red interactions, so moderate and severe interactions, remained stable. And there was also a positive correlation between more severe interactions and increasing age. So what do we make about of this? I think there's a couple of things to consider. As mentioned before, there is a shift, as we know, from older less-preferred agents like protease inhibitors and the older RTIs to second-generation integrase inhibitors. There's also an increasing shift from using 3-drug regimens to 2-drug regimens in many cases and long-acting treatments. However, this is counterbalanced by the fact that we have an aging population with high rates of polypharmacy. Older people may also have more multi-resistant virus requiring more complex treatment regimens depending on their resistance history. And even newer drugs aren't completely free from interactions. What type of interactions are important with modern ARVs then? We're going to focus on 2 main mechanisms, absorption and metabolism. And these are, again, mostly pharmacokinetic types of interactions. The first mechanism of absorption interactions are those which involve changing the gastric pH. Certain drugs like rilpivirine, oral, and the protease inhibitor atazanavir require an acidic medium for optimal absorption. So they're contraindicated with proton pump inhibitors, and there are also interactions with H2 receptor antagonists and antacids. Sometimes these can be managed with spacing drugs apart, or you can consider substituting with an alternate antiretroviral either within the same class or a different class altogether. So for instance, instead of rilpivirine, you can go to doravirine or atazanavir to darunavir, or switching to something else altogether like a second-generation INSTI. The second type of absorption interaction that's relevant are chelation interactions. And so cations can bind with all orally administered integrase inhibitors. When they do this, they form a poorly absorbable complex in the GI tract, thus inhibiting absorption, anywhere from 60 to 80% reduction of these integrase inhibitors. You can manage this drug interaction by spacing the integrase inhibitor apart from the cations or giving them together with food. It's important to note that the specific recommendations for how to manage this do differ slightly from one integrase inhibitor to another. So it's best to check the specific manufacturer guidelines. This it is a significant interaction. There have been numerous retrospective studies and case reports showing that use of polyvalent cations while on integrase inhibitors has been associated with an increased risk of virologic failure. Moving on to interactions involving the cytochrome P450 system or even drug transporters, I found that an helpful way to think about this is this revolving door analogy that I like to use. So think about a person entering a building, sort of doing their job, and then when they're done, they have to line up and exit through one of those large revolving doors that moves at a fixed pace. So we, in the same way, we think of the drug as a substrate entering the body, and then leaving eventually through the enzyme or transporter pathway. Inhibition interactions occur when two drugs compete for the same binding site or transporter site. With the revolving door analogy, think of an inhibitor as somebody who cuts in front of you in line while you're waiting to exit. So when this happens, you have to wait, you wind up waiting longer before being able to leave. And if there's a lot of people butting in front of you, this can cause quite a buildup, a backlog of people waiting their turn. Perpetrators of inhibition interactions include all protease inhibitors and boosted regimens. Some integrase inhibitors and fostemsavir can inhibit certain transporters, and lenacapavir is a moderate CYP3A4 inhibitor. Common co-medication inhibition perpetrators include azole antifungals and macrolides, which can be strong inhibitors of CYP3A4 or P-glycoprotein. Usually, when we think of the time course of inhibition, it's often a competitive and reversible process. So somebody cuts in front of you in line, you have to wait, and drug concentrations increase. When it's finally your turn, then you can exit, and then things go back to normal. So usually a quick onset of a couple days on and off once the inhibitor is removed. Now, there's some, really great things about using this aspect or using this characteristic of certain drugs. So with PK boosters, they're used to allow us to decrease the pill burden and dosing frequency while increasing drug concentration. So as in the case of boosted PIs or the older integrase elvitegravir, even one of the early hepatitis C antivirals, paritaprevir, was given with ritonavir as part of whole cure pack using the same principle. And more recently, the COVID antiviral nirmatrelvir was co-formulated with ritonavir as Paxlovid, again, to take advantage of the boosting principles. On the other hand, if you increase drugs, concentrations of certain drugs with a very narrow therapeutic index, this can lead to significant morbidity or even mortality. With some statins like simvastatin or lovastatin, which are very sensitive CYP3A4 substrates, there have been many case reports of rhabdomyolysis when they're given with the boosters. There's also been cases of fatalities when ritonavir has been used with drugs like MDMA or fentanyl, again, drugs with a very narrow therapeutic window. Now, let's use a case to illustrate an example. This is a 60-year-old gentleman, positive for over 30 years with an extensive antiretroviral history and lots of resistance, been virally suppressed for over 10 years on a combination including some nucleosides, efavirenz, and twice-daily dronabinol-ritonavir. After a recent diagnosis of diffuse large B-cell lymphoma, he met with the oncologist, and the plan was to start CHOP for 6 cycles. Now, the oncologist correctly identified that ritonavir was a perpetrator of drug interactions. So what they did was they stopped the ritonavir but continued everything else in this patient's regimen. We know that's a big no-no because ritonavir is there specifically as a booster for darunavir, so removing it will result in insufficient darunavir exposures to inhibit viral replication. We actually didn't find out about what had happened until the patient returned to our clinic 3 months later for a usual follow-up, and we noted that the viral load was now detectable. Doing therapeutic drug monitoring showed subtherapeutic levels of darunavir, again thought to be both to the absence of the ritonavir booster as well as the impact of efavirenz, which he was still taking, and that's an enzyme inducer. Unfortunately, and this patient already had a number of darunavir resistance mutations. Ritonavir was restarted at that point, but unfortunately, we were unable to completely resuppress them. I think a few more resistance mutations had popped up during this time. Luckily, in the end, we were able to add another drug, an integrase inhibitor, to get him virally suppressed. So some practical considerations when thinking about inhibition interactions. One is if you're using a booster for an antiretroviral, it's important to take it at the same time as the partner agent. I know some patients like to space out drugs throughout the day just to make it easier on their stomach, but it is really important if they're taking ritonavir to take it at the same time as their partner drug. This graph on the left just shows a study of people who are on twice daily boosted sequinavir-ritonavir, and for one dose, they skipped their morning ritonavir dose, but took sequinavir, and you can see there was a significant reduction. So that evening dose from 12 hours before was not enough to boost the morning dose of sequinavir. With respect to co-medications, as we talked about, the onset is pretty quick for these inhibition interactions, and you can manage it by reducing the dose of the substrate drug. It's a good idea to give patients a heads up, to counsel them to monitor for adverse effects or changes within the first few days after starting the inhibitor. Once you stop the inhibitor, you can resume the original dose once that drug is cleared. And again, you can also consider replacing the drug with something less likely to interact, so either from an ARV or a co-med standpoint. If it's possible, can you discontinue the co-medication, or do you need to, or can you do some additional monitoring? Another fun fact, sometimes interaction recommendations are different from country to country. So, for instance, with apixaban, giving it with strong CYP3A4 inhibitors is contraindicated in the Canadian monograph. It's not recommended in the European monograph, while the US package insert says that you can use it as long as you reduce the apixaban dose. And that's been that's been borne out in a number of case series where it's been safely used at a lower dose with boosted agents. So I think this is a good reminder that sometimes it's good to look beyond what's immediately available to us in terms of our own monograph recommendations, and see what else is out there and if that makes sense to you. So nothing wrong with a bit of cherry picking if it makes sense. Now, an important point I want to go over today is that although we think of cobicistat and ritonavir as being equivalent boosters for antiretrovirals, there are some differences. So I think of them more, instead of identical twins, more like fraternal twins. Sometimes ritonavir is a more potent inhibitor than cobicistat. So using this example of using boosting darunavir when you've got etravirine, which is a moderate inducer on board, you can see that if cobicistat is the booster, there's over a 50% reduction in darunavir trough concentrations, whereas if you use ritonavir as the booster, there's a lesser impact on darunavir concentration. So in this situation, ritonavir would be my preferred booster. Sometimes, cobicistat is a more potent inhibitor than ritonavir, and there are a couple examples here, one with quetiapine, another a study with dabigatran, showing that cobicistat increases concentrations of these PGP substrates to a greater extent compared to ritonavir. And here's an example of a gentleman treatment experienced, virally suppressed for quite a long time, and currently on a combination of dolutegravir and darunavir cobicistat. You can see there's a number of comorbidities and a lot of co-medications. He had a recent admission for falls and then an upper GI bleed, and his DOAC was changed from edoxaban to apixaban, 2.5 milligrams twice daily, due to his renal function. Now, we talked already about the recommendations for giving apixaban with a boosted PI, and the U.S. monograph says it's okay to reduce it to 50% of the dose, but only if in the situation of normal renal function. If somebody has impaired renal function, this should also be avoided. So what we did in this case was we replaced the PI with fostemsavir twice daily to go along with the dolutegravir once daily. 2 months later, this patient was being seen at a nephrology follow-up visit, and it was noted that he had an elevated blood pressure in the 200s. And the nephrologist asked the patient quite reasonably, well, what's changed, what's new? And the patient said, well, I started fostemsavir a couple months ago. So the nephrologist said, well, that must be it. Stop it and go back on your protease inhibitor. However, doing a bit of further thinking on this, hypertension is not mentioned in the fostemsavir monograph. It's not really a recognized side effect. And what probably was the more likely reason is that removal of darunavir, or of the darunavir cobicistat, likely led to a reduction in his diltiazem, in his blood pressure medication concentrations. This is a study showing the effect of adding or discontinuing ritonavir on amlodipine, so another calcium channel blocker, and the effects on blood pressure. And you can see really these changes happen quite quickly. If you remove the booster, the amlodipine concentrations go down, blood pressure goes up. Once we explain the mechanism of this interaction to the nephrologist, they then agreed to that it made sense to go back on fostemsavir and then titrate the diltiazem dose up as needed to manage the blood pressure. So remember that it's not just what you start, but also what you stop that is important for drug interactions. And again, the onset is rapid, and then if you remove the inhibitor over time, you might need to increase the dose of the target drug. To wrap up for today, then, Today we talked about some key concepts, pharmacokinetic versus pharmacodynamic interactions. We talked about pathways involved in drug metabolism, the CYP450 system and transporters. Major drug interaction mechanisms include drug absorption and metabolism. Inhibition interactions are very important and can increase concentrations of other drugs, which can either be a good or a bad thing. And these interactions generally have a quick onset and offset. And finally, we talked about some of the similarities and differences between boosters. So it's important to keep in mind not only when you're stopping boosters, but also perhaps switching boosters and to assess the impact of co-medications. So that's it for today. I hope that was helpful, and we look forward to continuing our learning in the next session.